Hello, this is a video lesson on the vertebral column, part 9B. We're going to talk about the lumbar spine, specifically the AP and the PA projections, the AP and PA oblique projections, the lateral projection, the L5S1 spot, and then the AP axial L5S1 projection. Starting off with the AP or PA projection, 40-inch SID is most common. However, 48 is suggested to reduce distortion and open intervertebral disc spaces more completely. The patient is recumbent. We're going to center the mid-sagittal plane to the midline of the image receptor, and we should reduce lumbar lordosis by flexing the hips and the knees to place the back in firm contact with the table. We should perform this with respiration at the end of expiration. For the lumbar sacral spine, we're going to center the image receptor at the level of the iliac crest, which is L4. In the lumbar spine only, we're going to direct the central ray perpendicular to the image receptor at 1.5 inches above the iliac crest to the level of L3. For the lumbar sacral spine, we'll adjust the collimation field to an 8 by 17 inch field size. For the lumbar spine, we're going to adjust the radiation field to 8 by 14. So for structures shown, we're going to see the lumbar bodies, the intervertebral disc spaces, interpediculate spaces, the lamina, the spinous, and the transverse processes. The image can be performed PA just as well. In the image on the left-hand side, we're looking at how the patient has the legs extended to this point. And so we've increased the lordotic curvature of the spine, and therefore we do not have the central ray entering the intervertebral disc spaces. On the other hand, with the patient with the legs, hips, and knees flexed, we're able to decrease that lordosis and then have the central ray enter the intervertebral disc spaces more evenly. The AP projection is performed more often. However, the PA projection places the intervertebral disc spaces at an angle closely paralleling the divergence of the beam of radiation. And here's 3 images showing the AP with the limbs extended, AP with the limbs flexed, and then the PA projection. So the evaluation criteria, we're looking here at just the AP lumbar spine, is that we want for the area from the lower thoracic spine to the sacrum. We want to the X-ray beam collimated to the lateral margin of the psoas muscles. There should be no artifact from the mid-atom from any elastic in the patient's underclothing, and there should be no rotation. The SI joint should be equidistant from the vertebral column, and we should see open intervertebral disc spaces, just like we have on the AP axial C-spine and the AP T-spine. The lateral projection is performed also at 40-inch SID, but 48 inches is recommended. We can perform the lateral projection on the table or upright. If the patient is recumbent, we want to flex the hips and knees for comfort and align the mid-coronal plane to the midline of the image receptor. The elbows should be flexed and at right angles. We want to superimpose the knees and place a small sponge, as can be shown, between them. A radiolucent sponge should be located beneath the lower thorax so that the spine is horizontal. The lumbar spine should be performed with the respiration at the end of expiration. For the lumbar sacral spine, we're going to perform the perpendicular to the image receptor at the level of L4, which is the iliac crest. And for the lumbar spine only, we're going to be perpendicular to the image receptor 1.5 inches above the iliac crest at the level of L3. If the spine is not horizontal, we're going to go with a direction of the central ray caudad. It'll be 5 degrees for males and 8 degrees for females because females have larger hips. We're going to also include that lead behind the patient so we can absorb scatter radiation coming from the patient. For the lumbar sacral spine, we're going to adjust the image receptor size to 8 by 17 and for the lumbar spine to 8 by 14. So the structures shown, we'll see the lumbar bodies, the intervertebral disc spaces, the spinous processes, and the lumbosacral junction. We're going to see the intervertebral foramen of L1 to L4. L5 intervertebral foramen are not usually well seen because of their oblique direction. So looking at the image that we can see, looking at the from L1, which is located here, down to L5, we're looking at a lateral projection. We can see the lumbar bodies and the intervertebral disc bases, the spinous processes, and then the intervertebral foramina shown in the image. And there should be no rotation. On the lateral projection, or otherwise called the spot, L5-S1 lumbar sacral junction, the patient should be in a lateral recumbent position, and we should have the sponge beneath the lower thorax again. The midcoronal plane is aligned perpendicular to the mid-receptor. We should still have our elbows, patient's elbows flexed and the determined arm at right angles to the body. We're going to flex the hips and the knees and place that support beneath them. And then and for respiration, we can suspend respiration. We're going to direct our beam perpendicular to the image receptor and on the coronal plane 2 inches posterior to the ACES and 1.5 inches inferior to the iliac crest. If the spine is not horizontal, then we will use a 5-degree caudate angulation for males and 8-degree caudate angulation for females, which is shown in the center. If your patient is larger, you may have to go the opposite direction. You can adjust your radiation field to 6/8, and we're going to see the lumbosacral junction, the lower 1 or 2 lumbar vertebrae, and the upper sacrum. So taking a look at the image, we're going to see the lumbosacral joint in the center of the image. So here's L5. And we've got S1 here, and we're looking at that space is what our viewpoint is what we're wanting. The ilia should be close together so they're superimposing us when the X-ray beam is not angled. Oblique projections. The AP oblique projections are performed at 30 to 60-degree obliques. The patient should be recumbent or upright. For the lumbar spine, we're going to have the patient turn from the supine position toward the site of interest approximately 45 degrees. Technically, L1 would be about 30 degrees, and then L5-S1 would be a 60-degree oblique. The long axis of the patient is parallel with the long axis of the table. You want to center the spine to the midline of the image receptor. The arm should be in a comfortable position and place the support under the shoulder, the hip, and the knee to prevent patient motion. We should have a sponge beneath the patient in this case. We want to suspend at the end of expiration, and for the lumbar spine, we want to direct the beam perpendicular 2 inches medial to the elevated ACES and 1 to 1.5 inches above the iliac crest at the level of L3. If you're performing this for just L5-S1, which is rather rare, you perform this still 2 inches medial to the elevated ACES, but you're going to go midline between the iliac crest and the ACES this time. And we're going to do this with, for the 9x12 for 10x12 inch image receptor, 9x14 by 17 inch image receptor, and for an 8x10, we'll look at the L5, we'll just do an L5-S1. So we're going to look at the articular processes at the side closest to the image receptor is the goal, and when the patient's been properly positioned, they should have the appearance of Scotty dogs. So the PA projection is going to be the same thing, except that the patient now is just in the opposite position. The OID is increased because we're going to open on the side furthest from the image receptor now rather than closest. The same positioning applies, the same respiration applies, and the same centering applies actually. Even the collimation is the same. The difference is we're looking at the side furthest from the image receptor. As far as evaluation criteria, we're looking at the area from the lower T-spine to the sacrum, and we should see the Scotty dogs. We should see the, on the AP oblique, we're going to see the side closest to the image receptor. When we're looking at the PA oblique, we're going to see the side furthest from the image receptor. And we'll take a look at these two statements here. When the joint is not well visualized in the pedicles anterior, then the patient was not rotated enough, which is what the top picture is showing. And if the joint is not well visualized, pedicle is too far posterior, which is what's shown in B, then the body is rotated too much. And we'll take a look at those. So in the image shown here, we're looking at the Scotty dog. We can see that the pedicle is the transverse process. The superior articular process is the ear of the Scotty dog. We're looking at the eye being the pedicle. The inferior articular process is the paw or the foot, and then the body is the pedicle. And so if the pedicle is too far anterior on the vertebral body, which we'll take a look at, there was not enough rotation. And that's exactly what we see here. So we're looking at the image that we're showing on the left-hand side is an LPO. How we know that is the Scotty dogs are facing to the left. The, the ilia or the ala is very flat on the left side. And third, the right SI joint is visualized. It's crunched. So we're looking at an LPO position. Well, the problem with this LPO position is it's not rotated enough so that the eyes of the Scotty dog, which are the pedicles, are very anterior, which is closest to the front of the anterior surface. So it's almost like an AP projection. So the patient wasn't rotated enough. On the other hand, if the pedicles are located too far posterior, which is what is shown here, then the problem is the patient was over-rotated. And this is an example of where these are the pedicles here with the notches that we can see, and we shouldn't be seeing that pedicle so far posterior. It's almost to a lateral projection. Now the SI joints, we have an AP axial projection, and then we have AP and PA obliques. On the AP axial projection lumbosacral junction in SI joints is called the Ferguson method. Your patient is supine and their mid-sagittal plane is centered to the image receptor. We want to ensure the pelvis is not rotated. We're going to perform this on suspension. We're to direct the central weight to the lumbosacral spine at 30 to 35 degrees cephalad. That's a big angle. We want to use 30 degrees for males and 35 degrees for females. We're going to center 1.5 inches superior to the pubic symphysis, or you could go 2 to 2.5 inches inferior to the ACES. Our collimation is going to be an 8 by 10, and we're going to look at the lumbosacral joint and the symmetric images of both SI joints free of superimposition. So here is the L5-S1 joint, and then we can see also the SI joints that are visualized bilaterally. On the AP oblique projection, the patient is supine. We're going to rotate our patient, oblique our patient 25 to 30 degrees, and the side that's being examined is further from the image receptor. We're looking at the side that's up or furthest from the image receptor. So we're going to adjust the body so its long axis parallel with the long axis of the table. I'm going to perform this on respiration and suspension. We're going to enter 1 inch medial to the elevated ACES. Our collimation is a 6 by 10, and we're going to look at the SI joint furthest from the image receptor and an oblique projection of the adjacent structures. Both sides are examined for comparison. We can also do a PA oblique projection instead with the patient prone. We'll do the exact same rotation, except for we're looking at the side closest to the image receptor this time. We're going to do the exact same directions, except that the SI joint, like I said before, closest to the image receptor is shown, and we'll do both sides for comparison. And so looking at the AP oblique projection, which is furthest from the image receptor or away, the PA oblique projection, we're going to look at the SI joint closest to or toward the image receptor, and we're just going to open up that sacroiliac joint. The sacrum and coccyx. We have four images we'll take a look at. There's the apiaxial of the sacrum, apiaxial of the coccyx, the lateral sacrum and coccyx combined, and then the lateral sacrum or coccyx separated. So the apiaxial projection of the sacrum lies at a natural 30-degree angle in the body. Natural 30-degree angle in the body. So we're going to angle 15 degrees, which is half of that angle formed by the body, in the opposite direction to see the sacrum, so it's not foreshortened. We're going to make sure that the bowel does not interfere, and also that the urinary bladder is empty before the exam. We're going to perform this study supine if possible. Sometimes I've had to perform it prone for reasons that the patient was in too much pain. Center the mid-sagittal plane of the body to the midline of the image receptor. The ACEs should be equidistant from the table and place a support under the patient's knees. We're going to suspend respiration. As I said before, we're going to angle 15 degrees cephalad. You're going to enter 2 inches superior to the pubic symphysis. We're going to collimate down to a 10 by 12, and the sacrum should be free of superimposition and should not be foreshortened. The coccyx, on the other hand, lies at a natural 20-degree angle in the body, 20 degrees. So we're going to angle 10 degrees in the opposite direction, 10 degrees in the opposite direction, and the same notes apply about the bowel content as well as the bladder. The patient is still supine. We're going to send to the mid-sagittal plane of the body to the midline of the image receptor. The ACEs should be equidistant from the table, and we're going to put a support under the patient's knees. We're going to suspend respiration. The central ray should be directed 10 degrees caudad and centered 2 inches superior to the pubic symphysis. We're going to adjust the radiation field to an 8 by 10, and the coccyx should be free of superimposition with no foreshortening. And so taking a look at the two images, on the left is the sacrum and the right is the coccyx. We're looking at the sacrum and at the coccyx both centered. They're neither one foreshortened, and the pubic bones do not overlap either one. There also should be no rotation. On the lateral projection of the sacrum and the coccyx, we're going to have the patient turn on their side. We like to put a sponge underneath their lower thorax again, and we're going to put an apron behind to take care of that scatter radiation again. We're going to place a sponge between the patient's knees, and we're going to make sure the interiliac plane is perpendicular to the image receptor. We're going to suspend respiration, and we're going to direct the central ray to the level of the ACEs and 3.5 inches posterior. So here's the level of the ACEs, and we're going to go 3.5 inches posterior. This is for the sacrum or the sacrum and coccyx. We're going to adjust our field to a 10 by 12, and we're going to see a lateral projection of the sacrum and the coccyx. We can do the exact same positioning for just the sacrum, the exact same positioning. We're going to do 3.5 inches posterior to the ACEs, the level of the ACEs. The coccyx, on the other hand, we're going to do the exact same positioning, except we're going to start off at the ACEs. We're going to direct our to a position 3.5 inches posterior and 2 inches inferior. So 3.5 inches posterior and 2 inches inferior. And that's because we're going to get a lateral projection of just the coccyx and adjust our radiation field to 6 by 8. So the two images that are shown, on the left-hand side is the sacrum and the coccyx, and the right is just the coccyx. Now we do have what is called the scoliosis series. The scoliosis series, this is a common projection where we're just looking at a 14 by 17 being used with the thoracolumbar area being shown. This can be performed AP or PA and a lot with the lateral projection. So The method that's recommended in Merrill's is to do PA and lateral projections, where we do either just a PA and lateral projection where it's just an 8 by 14 by 17. The other option is to do 3 views. So we'll take a look at that. So what this is going to do is it's going to be looking at the degree of curvature that occurs with the force of gravity acting on the body and evaluates fixation devices such as Harrington rods. The patient is always upright for a scoliosis study. The PA is preferred because the patient would receive less dose to the breast. These are performed in adolescent patients and typically females, and so their dose to the breast would be decreased by the PA projection. Actually, it's only 1% of the dose that would be received on the AP projection. We want to center the mid-sagittal plane to the midline of the vertical grid device. In the lateral projection, we're going to adjust the position of the patient so the mid-sagittal plane is parallel with the IR and patient's shoulder is touching the grid device. And so we're going to center the thorax to the grid. The mid-coronal plane should be perpendicular and centered to the midline of the image receptor. We want to have the arms upright for the lateral projection. We're going to have the patient suspend respiration, and we're going to be perpendicular to the center of the image receptor. Now for the this exam, we should have 2 to 3 image sequences performed for the PA and lateral projections. It really depends upon the type of imaging system and also the extent of the patient's scoliosis. But you only want to include the anatomy of interest. Always check previous exam images to determine the extent of the curvature too. The structures shown ideally should include the spine from the tip of the skull to the tip of the coccyx, but that just depends upon protocol. So computers, depending upon the computer system you have, can digitally stitch images together to create one image. So here's the different way of performing this, where we have 3 separate images where we see the cervical, the thoracic, and the lumbar perform PA and then lateral. And then the images are digitally stitched together to show all 3 spines. Other projections include the AP projection, right and left bending, and then the lateral projection flexion and the lateral projection extension. And here's the patient, by the way, with the scoliosis and with the Harrington rods. And this is a good reason why we want to look at bending views, even flexion extension views as well. So the AP projection for right and left bending. So this is performed in an AP projection. It's used for spinal fusion. The patient can be upright or can be supine, and the mid-sagittal plane of the body is centered to the midline of the image receptor. So we're going to take the first radiograph with maximum right bending and take the second one with maximum left bending, whatever the patient can possibly do. And we're going to immobilize the heels with sandbags. We're going to suspend respiration. We're going to center it to the level of 1.5 inches, 1 to 1.5 inches above the level of the iliac crest at L3. And we're going to adjust to either 10 by 12 or 14 by 17, depending upon the protocol. So we're going to see the lumbar vertebra in maximum right and left bending. We're going to evaluate the integrity, 3 reasons why, to evaluate integrity of a spinal fusion, usually 6 months after the spinal fusion procedure. It could be used in patients with early scoliosis to determine the presence of structural changes, and to localize a herniated disc, which would be a cheaper way to do so and less radiation dose than a CT, for example, or a lot less money than an MRI. And so here's your 2 images with the patient bending to the right and bending to the left. The side of the spinal, if there is a spinal fusion, it should be in the center of the image. Flexion extension views, just like the cervical spine, are performed in lateral projections. That's how you're going to do your flexion extensions. So the first image at the top is going to be the flexion, and then one at the bottom is extension. We're going to have the patient flex and extend as much as possible, whatever is reasonable, suspend respiration, and we're going to be perpendicular to the spinal fusion area or to L3, adjust the radiation field to 14 by 17. You're going to have two lateral projections, and for three reasons. Determine if motion is present in the area of a spinal fusion, indicate a non-union, or to look for a herniated disc. And here's our two images that we can see. The one on the left is the one in flexion and the one on the right in extension. So the proper marker should be used for each respective position. And this concludes our video lesson on the second part of the procedures of the vertebral column.